As we know, the Supreme Court is expected to rule near the end of June on the constitutionality of the health law. If the Supreme Court strikes down the health law, what does that mean for Michigan? What's next?
Well, I think we keep doing what we've been doing. There'd be the status quo. And, certainly there are always, there's always interest in moving the health system forward and improving things. And the governor has been on record as saying an exchange is a good idea in general, not necessarily the ACA envisioned exchange, but whether he would make that a priority or not, I really couldn't say. So I think mostly we're back to business as usual, and business as usual in Michigan is pretty good in the healthcare world.
So if the law is upheld, how do you see the implementation moving forward? There's been some concern that some states won't be ready on time. Will Michigan be able to be ready on time for the health law if it's upheld?
I think it will be a struggle. Certainly if the law is upheld, I think there's enough interest in the state to have it be as state-centric as possible, and so I think we'll kick it into high gear, and those that are really much more familiar with the specifics would have to make some decisions about whether we can actually achieve the milestones and do the preparations to have a state-only exchange, or whether we would have to engage in a federal partnership model in some way.
Do you think, since you run the Medicaid program, would you be able to handle that influx of new Medicaid beneficiaries if the law is upheld? Would you be on track to be able to handle that, or do you think the state would need more time for that?
No, I think we can handle that. We have a lot of plan capacity in the state. Certainly we're concerned about the eligibility system, just being able to process the number of new applicants and have that work in a timely way. But we believe we have the capacity to handle the new beneficiaries, and would look forward to having health care provided to many of those in need.
Now currently, Michigan has, I believe, 75% of your Medicaid enrollment is in managed care. And the health law allows states on a demonstration basis to put the dual eligibles, these are the sickest and frailest beneficiaries, they qualify for Medicare and Medicaid, to put those dual eligibles into managed care. There's been some controversy about this. How do you think Michigan would proceed with the dually eligible?
Well, we've already made we're one of the 15 states that requested and received $1 million in planning money about a year ago. We've worked very hard to work with consumers and advocates and provider groups, all the different stakeholders, to put together a plan for Michigan. And we submitted a proposal at the end of April to the federal government to put to the entire dual eligible population, those that at least have full coverage, into this demonstration program, because we believe that the care system can be greatly improved.
There is controversy about putting the duals in managed care, that perhaps they'll have to leave systems. They go into a demonstration project, they leave their current provider or their community health center. If the demonstration project doesn't work, they can't go back to those. If there are continued budget pressures on states, the states will go to the federal government and want to cut spending on Medicaid, including those dually eligible. How do you safeguard and make sure that there are enough providers, that these folks are protected, and that if there are problems, that they won't be hurt by them?
Okay, well, a number of things to say about that. Number one, we have, like you said, 70 to 75% of our current population in managed care, and that includes all the adult disabled population that's not dual eligible. And we've had that population in mandatory managed care for 15 years in Michigan, so we have a lot of experience with that population. Our emphasis in Michigan is on quality, so when we do procurements, we choose plans based on quality. We actually set price. We have a number of quality components to the program in terms of doing financial incentives for certain quality, achieving certain quality benchmarks. We have auto assignments where individuals actually don't select a plan. We advantage the plans that have higher quality to get more of those auto assignments. We monitor the plans on various HEDIS and CAPS measures, and we even provide a scorecard where we rate plans competing against themselves on a 1, 2, and 3-star system on different care components that go to beneficiaries to help choose a plan. We don't allow marketing. We have an enrollment broker that's a neutral party that provides objective information, tries to make sure if an individual has a primary care doctor, they can choose a plan that primary care doctor participates in. So we have a lot of safeguards around that. In terms of network adequacy and making sure there are sufficient providers, Medicare has certain standards that they use. We use, I think, similar standards to make sure that there is capacity. Plans have to have a primary care available in order to enroll someone because we insist that there be a connection, that an individual beneficiary be attached to a primary care provider so that they have a source of primary care from the get-go. So we have numerous protections in place that we think will assure that there's quality care.